Okay, this is going to be products that a physician, you'll recommend for a physician using for the intraoral blocks prior to starting the lip augmentation. What we recommend is that they use some type of a product to use intraorally to numb the mucosa prior to the injections. These products can be used, there's lidocaine on the market, there's a gel, and there's a lidocaine spray. Trademark names are Hurricane, but they would use this and either use it on a Q-tips for the gel or the spray, and this will anesthetize the intramucosa of the mouth prior to the injections, which will be make it easier and more comfortable for the patients. Your products that are going to be injected and that we recommend is a 1% lidocaine with epinephrine. The epinephrine causes vasoconstriction, which will minimize the bleeding. The other product that we'll recommend is sodium bicarb, and the reason why we would recommend the sodium bicarb is that your local has an acid base, or it is an acid base, so it burns and stings when it's injected, and the bicarb will neutralize the acidity of the local and just makes the local product more tolerable to the patient when injecting. About 9 cc's of local with 3 cc's of sodium bicarb is a good dilution ratio, which will give you a proper anesthesis of the lips, along with giving them enough product to do their injections. The gauge of the needle will be a 30 gauge 1-inch that we recommend, and this will be carried out for the intraoral injections along with the injections of the lips and the oral commissure. The tray that we have set up here will basically demonstrate what is recommended to do the lip augmentation. I'm going to start over with, like at the beginning of the procedure, a physician would have 2 choices on what he would like to use as far as instrumentation to make his initial incision. This is a knife handle. On the end of a knife handle, you can change up your attachments. This one happens to be a 15 blade. You'll hear some physicians asking if they can use a 11 blade. That is also acceptable. The second product or instrument that you will see on the tray is a curved iris. Now, what makes this iris different from the one that I'll show you on the tray is that it does have an angle or a curve to the tip. Notice that the tip of this instrument also is sharp, and this will help ease the dissection and minimize the trauma to the submucosa. The third instrument we have is a brown adson. The brown adson is different from a regular adson, and it has multiple teeth on the end. This will help with grasping of the implant when they're getting ready to pull the implant through the lip. The multiple teeth minimizes the amount of trauma that will be applied to the implant during the procedure. The next instrument, of course, you're familiar with is the PermaTunneler. This is an instrument that I recommend that the physician use and place in his hand prior to using it during the surgical procedure, so that he can get comfortable with using it and with his ease of insertion and handling that implant or that tunnel. The next instruments that are available are the straight iris. Again, showing that it is just straight. This is an instrument that I recommend using only to cut suture. I don't recommend a physician trying to use this to do his initial dissection. I think he'll have difficulty, and I think it will prevent him from being able to properly plane the lip. The next instrument that we have is a needle holder, and that is what's going to be used for his suture closure, along with a adson. And the adson has a single tooth, and it basically is going to help with the closure so that the physician can pick up some of the tissue, because do remember on our closure you need to get a little bit of the deep submucosa to prevent migration of the implant and exposure. The sutures that we recommend is going to be some type of a dissolvable suture. You'll see on the tray here we have 4-O-Capricin. A physician can use a 4-O-Chromic, but you want a product that will stay in the incision site for approximately 10 to 14 days and decrease any type of irritation or reaction. We do want a physician to treat this procedure as a sterile procedure. A lot of doctors try to claim that since it's in the mouth that they can do this without being a sterile procedure. But do understand, since there is an implant involved, we recommend a degree of sterility. You'll notice that we have towels, which you'll see will be blocked around the patient to keep your field sterile. You'll also want to make sure that they have a little bowl or some type of little basin that we will have them place their betadine solution in. And this is what your implant is going to be inserted in to help with the ease of pulling it through the lip. You'll also see this demonstrated that we'll apply this to the tunneler because it also helps ease the insertion of the tunneler during the procedure. And then the basic 4x4s, and that will be for just any minor bleeding that possibly will occur during this procedure. Prior to the physician getting started doing the procedure, you'll want to make sure that he's comfortable using the tunneler, the Perma tunneler. What you want to make sure is that he is comfortable putting it in his hands. You want the physician not to put his fingers in the rings of the tunneler because it will have a larger tendency, or he'll have a greater tendency of opening up the jaws of the tunneler when he's going through the lips, which will tear up a lot of this submucosa and make the procedure extremely difficult. So make sure that he grasps the handpiece in the palm of his hands and make sure he has some form of good leverage on it. This will give him the ability to use wrist action in both directions, because you will need to use, or the physician will need to use, a little bit of a wrist action as he is progressing the tunneler through the lip. Now what you'll notice is that the physician, as he's advancing the tunneler through the lip, during the central part of the lip, you'll notice that he may come upon a little bit more resistance. And with that, that's when it's going to be very important that he uses a little bit of wrist action. And this will be not as extreme, but he'll need to use a little wrist action and sometimes back and forth slightly. Because what you don't want is for him to just try to ram the tunneler through, because it will increase his risk of perforating through the lip itself. Now, when you grab the lip, which we're going to show you here, you're going to grab the lip, and the physician needs to make sure that all the time that he's advancing this tunneler in, that he has total visualization of the wet-dry border, which is indicated right here. So once he's advanced in, any type of little action that he needs to do, even advancing across the central part, will need to be done with using the wrist. Always make sure that the physician supports the lip that he's advancing the tunneler into. That way he'll maintain control of the procedure.
What this ruler has is an area in which it's 55 millimeters in length, which is this one, which is on the same side as the telephone information. And then there's the 60, which is 6 centimeters, and the 65, or 6.5 centimeters. So this is the three lengths. So in order to size the patient correctly in terms of length of the implant, which right now there's only 3 choices, but we're going to be coming out with a 70 or 7 centimeter one as well in the future. This ruler is extremely valuable. So what I do is I place this up against the patient's mouth, going from their commissure and starting it right at the very end, and then I see which one of these fits the best. I want to try to get this implant to go from almost precisely from corner of the mouth to corner of the mouth. And in this particular patient, I've already measured her, and it's 60, but I'll go ahead and show you on her where I get that from. The other thing that you need to know that's of importance in terms of these measuring is that the upper lip is frequently longer than the lower lip, and so the reason for that is because there's more curvature with the upper lip. The lower lip is a straighter lip just in general. So you should not have a doctor that has measured the patient and needs a smaller one on the upper lip. That would be a mistake. It's at least the same, and frequently it's longer. So what we're doing here is we're using the paper ruler and bending it around her lower lip, and it appears as though the 60mm implant will fit nicely. So we're bending the ruler once again around the upper lip, and the 60mm implant is the correct length once again.
Okay. And what you'll notice, as we discussed previously, is we'll have the patient slightly open the mouth, and this is where the topical local will be used prior to the injections. And again, this is under the discretion of a surgeon if he chooses to use this, but again, it really decreases the discomfort for the patient. You'll want to allow this to sit and kind of have a tendency for the topical local to work for a few minutes, and then I just have the patient just slightly close their lips for comfort. Once you've given at least 3 to 5 minutes for the topical local to work, we'll go ahead and remove the little applicators, and then it'll be time for the physician to go ahead and start his injections.
The doctor typically will pull down the lip. The injection goes essentially at the canine, so you just have to find the eye tooth or canine tooth, and then it just goes right in at the base, right. It's hard for you to see, but and I typically will shake, and a lot of doctors, notice that a lot of doctors will kind of shake the lip for this because it's a great distraction tool. The syringe, which typically starts out at around 12 cc's, I've already injected about 1.5 cc's into her left side. And you can see that she's already developed a little bit of swelling here from where the injection has taken place. I'm now going over to the right side to do the mental nerve on the right side, and we will inject, and I hope that you can see this clearly, another 1.5 cc's. And I'll shake once again, I'll shake this area, shake the lip for distraction purposes. And you'll see how it kind of fills up, and then on the outside, you'll note there's also some swelling there. The nerves basically go along, if the patient is looking straight ahead, along their pupil line can be found the infraorbital nerve, which would be approximately right here on her left side, and then the mental nerve is located again below that, but above the jaw. And when you're opening up the mouth and you see the canine teeth, that is a great clue as to where the pupillary line is where the canine teeth are. So now we'll go and do the infraorbital nerves, which are essentially here and here. Go ahead. Now we will inject and I'll shake. So now we're ready to inject the right infraorbital nerve, which is approximately right here, and I'll start shaking. And once again, we'll inject approximately 1.5 cc's, and you'll see this area as it kind of fills up with the local, and then I'm done. You'll see some doctors will inject from inside the mouth into all of these nerves, and then other doctors, you'll see they'll actually go through the skin, and either way is acceptable. We prefer to go through the skin of the mouth, the intraoral mucosal approach. Now, some doctors also like to numb up the nerve that's essentially in the midline of the upper lip, and we like to do that as well. So we're going to inject this area, which is called the inferior alveolar nerve, and so we'll just kind of right into this area here is where we will inject, and it once again will be 1 to 1.5 cc's of the local. So this one hurts a little bit more, so you got to go a little bit more slowly It's a more tender area. Okay. Now we're going to let that sit for approximately 5 to 10 minutes. Let that local really work on each of these nerves, and then we will proceed to do a block of the actual lips themselves into the lip, and I'll show you the guidelines that we use for how much and where exactly that we will inject. Review some of the anatomy that's involved with this surgery. Specifically, the corners of the mouth, which are located here and here, are called the commissures. The upper lip is called, and the lower lip in the pink portions are called the vermilion. The vermilion border is the border or the area that represents a line of demarcation where the lip goes from pink to white. That's the vermilion border. The area above the vermilion border, where the white skin is here, is called, we call that the labrum. Now, in terms of the lip itself, other than the commissure, the other main landmark that you must be extremely familiar with is the wet-dry border. And the wet-dry border is that portion of the lip that goes from the dry part to the wet, or the wrinkled to the smooth, and you can clearly see that in most people, and in her I would say that it runs roughly this line here. From your camera angle, you can see it roughly going here. This is the area beneath the implant will go. So our dissection, in terms of where we're going to be trying to create the tunnel, will be directly beneath the wet-dry border, but is going to be superficial to the muscle of the mouth, which is called the orbicularis oris. And we can't see the orbicularis oris, so we're not going to be pointing that out today. Now, she's had the 4 blocks for the nerves, plus she's had the one for the infraorbital nerve, the anterior alveolar nerve, inferior alveolar nerve. So we're going to now inject the commissures.
Stop.
Okay, now we'll start doing the injections. First, we'll do the commissures. So the needle goes in just a little ways right in there, and we'll inject just a half a cc in there, and then this other commissure about a half a cc here. You'll see it kind of blow up and fill with the local. Then once the commissures are done, then we'll begin doing the lips themselves. And I'll position the needle so that we're going parallel with the wet-dry border, which you'll notice is right here. So I'll just kind of pull the lip so that I can do it as a straight shot, and we will begin doing some hydrodissection with the local. Hydrodissection will permit the scissors or the tunneler or whatever we're using to slide more exactly, precisely in the area that we want to go. Plus, the local will help us with hemostasis because of the epinephrine that's mixed in with the local. So we're going along, and note specifically that there is minimal distortion of the upper lip with this injection. So we're injecting about 2 or 3 cc's into each of the lips. So 2 or 3 cc's into the upper lip and 2 or 3 cc's into the lower lip. I'm just going to increase this a little bit more to just have a little bit better symmetry between the two sides. Now we can start doing the lower lip, and once again it's the same mechanism where we will inject about 2 or 3 cc's, and it's basically going to go along the wet-dry border. And all this part is very important just for it will improve the quality of our procedure, because there will be less bleeding, there will be less swelling afterwards. Okay. Okay. Notice how the lips have blanched some and lost some of the pink color and become a little bit wider. That is our clue that the epinephrine in the lidocaine, which is the local numbing medicine, that is our clue that she is now ready for the prep and then to have the procedure. So, what we prefer to use is betadine, and either solution or gel can be used, and we'll now paint the face and the lips, the entire area, and underneath the chin and beyond the nasolabial folds, which are the laugh lines, commonly referred to as the laugh lines, so that we'll have an area prepped that will be approximately this size here. Now, I also like to go inside the lips a little bit as well and prep a little bit on the inside too. Next, I will be applying the sterile towels. And I typically put one over the patient's eyes in case there is a bright light, and you'll see some of the surgeons will do that and others will not. We prefer, though, to do the entire procedure using a sterile technique because we are putting in an implant and we would like to tremendously reduce the chances of infection. So we now have her draped out quite adequately for this procedure. Okay, open your mouth a little bit. Okay, the two techniques that we can use for making the initial incision is that we can use the knife or we can use the scissors. I'm going to do one of each so that you can see how each one is performed. First, we will do the scissors, and we make the incision in the commissure, and I typically make my incision in the commissure with the scissors approximately 3 millimeters in length. Notice that the incision does not go past the vermilion border. I stay within the vermilion itself, and note also that there's no bleeding whatsoever, because I've only gone through just the very outside portion of the skin, and that is important later in the procedure. On the other side, I'm going to make the incision with the 15 blade, and I would recommend that the doctors that you're training make an incision that's a little bit longer than what you'll see me make, but note once again that this incision can be made bloodlessly with a 15 blade attached to a knife handle.
Now, as you'll notice, Dr. Harris has made about a 3 millimeter incision in both oral commissure. What you're going to notice and what we'd recommend is that physicians that are starting out learning this procedure, we'd recommend that they either do a 4, sometimes even a 5 millimeter incision. And the reason why is if you examine the tunneler, you're going to notice as the tunneler advances into the lip that the tunneler becomes a little thicker. And that way, until the physician becomes more comfortable with this procedure, it will minimize him putting stress on the incision sites, having a longer incision, which will prevent stress on the incision and possibly tearing of the mucosa, which is very fragile in the oral commissure. Again, Dr. Harris has separated or kind of put a little stress on the incision so that we can visualize and show you the incision site. You'll see the little pink mucosa that is visible, and that is the landmark that Dr. Harris is going to kind of puncture through gently. And then he's going to, and as you've noticed, he's angling the iris scissors upward, where you've got, see how he'll puncture through here, doing a little puncture site there, just gently going through, not wanting to go down deep, but he punctures through the little submucosa. And if you notice, he's got the tip of the iris scissor now landmarking the wet-dry border. Now, Dr. Harris will continue to support the upper and lower lip, visualizing the wet-dry border continuously in between his index and thumb finger. And always make sure that the physician is using the wet-dry border, and as you can visualize here, seeing that your instrumentation, that you should not be able to see it, but you can kind of see the pattern and the dissection mark under the wet-dry border. Now, the length of the dissection that Dr. Harris is currently performing is about, I'd say about an inch dissection. You'll see that patients that have had previous fillers, patients that have had previous lip procedures, that it is easier for the surgeon, and it'll be an easier insertion of the tunneler if we go ahead and do a longer dissection. Now, I'm going to have Dr. Harris show you the normal dissection on the right side here that you'll see a physician plane, and it is not as long as the original dissection. But remember, if a physician is having difficulty, then I recommend that you do a longer or a more advanced dissection with the iris scissors, closer and going towards the midline of the lip or the central part of the lip, because that will again decrease the amount of difficulty with the procedure and just decrease the amount of bruising and swelling that you have. Now, as Dr. Harris came out, you noticed that he advanced and did a little dissection on his way out. The dissection that we want you to do with the iris scissors, you want to kind of widen the pocket for your initial dissection. That will make it easier for you to locate and find the tunneler. The tunneler will make it easier for the tunneler to find your opposite area of dissection. Prior to inserting the tunneler, as we had discussed previously, demonstrating the instrumentation tray, you want to soak the implant in the betadine, and you also, remember, you want to put betadine on the tip of the tunneler, and I recommend advancing the betadine and kind of stroking the betadine down the tunneler, just because this will help wet the tunneler and ease the insertion of the tunneler itself. Now, again, Dr. Harris is going to support the lip, and we're going to gently insert the tunneler into the previously dissected area. And as you notice, he's going to kind of do some slight just back and forth wrist action to kind of help locate the tunnel. And if you noticed, you saw how the tunneler just advanced very easily into the pocket that we have originally dissected. Now, as you see, the tunneler goes up to a certain area of dissection, and Dr. Harris will continue to support the rest of the lip where the tunnel has not been made with the iris scissors, and he is just going to gently, with minimal pressure, with a back and forth wrist action, he's going to continue to complete the rest of the dissection with the tunneler. And you'll watch him do this as he supports the lip. He advances the tunneler into the lip that he has supported. You want the physician to always support the lip so that he so he always maintains control and will not have a tendency to perforate through the lip itself. And as you notice that Dr. Harris has already found the tunnel, which was very easy because of his previous dissection, and he's been able to advance the tunneler through the left incision through the right incision. And now the next thing he's doing, if you'll notice, Dr. Harris is now evaluating the amount of tissue that he has on top of the tunneler. If you have an excessive amount of tissue on top of the tunneler where you can pinch and it's a very meaty or fleshy type of grasp, then you want to evaluate to make sure that you have not gone too deep. Now, also, the nice thing about being able to evaluate this is you can see that the tunneler lays right along the wet-dry border, and you have pretty much equal dissection, and that helps determine that we've gotten a proper placement of this implant. Now the implants always come double peel packed, and that has been placed onto the back table prior to the physician needing it to minimize holding up a procedure. The one thing that you'll want to remember is you'll be doing this procedure in many different areas. It may be the physician's own operating room, it may be a procedure room, but the one thing that you want to do is make sure that they have verified the size that has been previously measured. It is, all implants, as you're aware of, come double peel packed. Your first peel pack is what you will open. The physician or his assistant will take the inside package of the peel pack, which will contain the sterile implant. They'll then place the implant in the betadine, and then once the physician has advanced the tunneler through and he's ready to put the implant in, you'll notice that Dr. Harris has already opened the jaws of the tunneler, and this implant is going to be placed completely into the jaw. What the tip of the tunneler needs to grasp the end or the thickest part of where the tapering of the implant starts. Now,
so it shouldn't be like this.
Right. You don't want to grasp just the tip of the implant, because that can, again, tear the implant, change some of the integrity of the implant. And so you want to make sure that the physician advances that implant all the way into the jaws, and then once he grasps it, remind the physician that he needs to always maintain his perch or his grasp of the implant. And then Dr. Harris is going to start advancing forward. But if you notice, Dr. Harris is going to support the lip, because you're going to have difficulty, there'll be a little difficulty advancing the tunneler first. So you want to kind of start with your initial pulling through of the implant by getting the tunneler to kind of start its process back through. And once that process is started, you want to make sure that the surgeon grasps the opposite end of the implant that's not attached or connected or placed into the tunneler, so that you do not pull the implant all the way through. Now, once that implant has been pulled through, you want to make sure that you have equal distance of the implant showing on both sides. And then Dr. Harris basically pulls the implant back and forth to allow proper seating of the implant, and then he releases the implant, showing that we had equal distance on each side. Once that implant has, you see the equal distance. If for some reason we have a little change, or there's one side of the implant that extrudes a little bit farther out than the other, have the surgeon pull on the opposite side of the lip to pull it through. But the normal procedure would be just stretching the lip, which will allow the ends of the implant just to go ahead and retract into the lip, so that you have no visual implant showing through the incision. Now Dr. Harris is evaluating the placement of the implant by feeling where the implant lays in the lip, and he is going to make sure that each end, or the tapered ends, are there's equal distance of that implant on each side. So you'll do that by evaluating where the ends of the implant lay. We're starting with the lower lip. Now remember, you only have the 2 incisions. You've already basically made both incisions, and so Dr. Harris again will repeat this same process, and that's going and doing just a small little pop through the submucosa, because we've already done the upper lip, but you're going to have the same process that the physician will need to do to advance into the proper plane of the lower lip. Now, some physicians will notice that it's easier to do the lower lip than the upper lip, but as you see, Dr. Harris is now proceeding with supporting the lip between his index and thumb fingers, and using the iris scissors to open and to continue to do his dissection and tunnel through the lower lip. He also, when he does his tunneling, as you notice, he does a little dissection. Well, that's kind of the fanning of the iris scissors inside the lip, to allow for the lateral pockets, or the insertion pockets, to be a little easier to find with your tunneler. As you can notice, you have some depth. You cannot visualize the instrumentation itself, so you do have a little bit of depth there, but you're not deep to the submucosa of the lip. And as he continues to advance with his iris scissor, as you see, he supports the lip tissue, and the lip tissue or the instrumentation is advanced into the supported tissue. You never want to have a surgeon that's not supporting the lip tissue, again, because remember that can cause perforation through the lip. Now, once Dr. Harris is finished with his dissection, again, he is adding the betadine to the tunneler to ease the insertion of the tunneler. And he will go in, and it will not matter if the physician wants to go on the right side first or the left side first. I think that's just physician preference and what he is most comfortable with. As you notice, finding the pocket should not be a forced issue, but one where the surgeon just kind of manipulates the entrance and the tunneler to find that dissected area or plane. Now again, Dr. Harris is supporting the lip tissue, always visualizing the wet-dry border, never forcing the tunneler through the lip tissue, but using a little wrist action back and forth, and that will just ease and cause minimal trauma and dissect through the lip tissue. We'll continue to advance, and you'll notice that once Dr. Harris reaches and locates the other pocket, that the total ease of inserting the tunneler through is easy. Now, one thing that I do want you to remember, that some physicians, when the tunneler starts advancing across the lip plane, the corners of the lips sometimes have a tendency to want to turn in. So always make sure that the physician visualizes his incision site, and he may have to do that with either an assistant, but you always want to make sure that he visualizes that so he doesn't create another opening. Now again, Dr. Harris is evaluating the amount of tissue, submucosal tissue that's on top of the tunneler. There's not an excessive amount of tissue. If there is enough tissue where the surgeon can pinch it, then what you would want to do is possibly retunnel.
Go ahead.
Now, as we had previously discussed, the implants come double pill packed, and Dr. Harris has the inside or the inner pack of your product, and he's going to demonstrate that you will grasp, there is like a little angle, and you will grasp both sleeves or sides of the package, and the implant then will be, the package is peeled back and the implant will lay in the center of the package. Remember, you always want your physician to verify the size just to minimize improper size placement. The implant is then placed again in the betadine, and once that is covered, remember that you're using the betadine to help again with the ease of the insertion of the implant being pulled through the lip. Remember again that we are going to place the implant all the way to the deep part of the jaws of the tunneler, making sure that the end of the tunneler grasps on the thickest part, and then Dr. Harris is now supporting the lip and starting to advance the tunneler through the lip, which supporting the lip will minimize the trauma and just help with the advancing the tunneler through the pocket that you've made. Once that implant or the tunneler has started advancing through, remember that you want the surgeon to always grasp that implant so we don't pull it all the way through the lip. If it does go through the lip, just have your surgeon retunnel. Again, we're what we call seating the implant, or making sure that the implant slides and glides easily through. Dr. Harris is then going to show you that he has equal distance of the implant visualized on both sides. If for some reason you have more implant hanging out, which you see we have a little bit more on our right side than the left, what you'll want to do is pick that side up and just gently advance that implant in, and then you'll continue to work the rest of the implant in through the lip. He will again evaluate the placement of the implant. He has put a little betadine on his fingers just to minimize the abrasion of the tissue of the lip when we're touching or feeling the patient's lips. And then once he is happy, or the physician is happy with the centering of the implant, the next step you'll go with is closure. Remember, as we had previously discussed, your suture product needs to be something that is absorbable. You can do the 4O Capricin. You'll see some surgeons use the 4O Chromic, but you want to have a suture that is strong enough that it will hold the incision because of the mobility and the movement of the mouth. When the incision is closed, we recommend interrupted sutures. We'll place 2 interrupteds on each incision, and as you see, Dr. Harris is making a little bit of a deeper type closure and grasping some of the deep submucosa of the lip that we originally had penetrated through, and that just will help with the closure of the incisions. And he's going to go ahead, as we said, and put in 2 interrupteds, and we'll do that closure just to minimize that if we do lose an incision or a suture, excuse me, and one comes out, you'll still have the incision closed. Now we're going to start again placing our second incision. If a suture, excuse me, you'll notice that Dr. Harris also places the knots to where they're inside the mouth, so that should not be visible, so the patient can go back and not have such a visible appearance if something's been done besides the bruising and swelling. But because the patient will have these in for a good 10 to 14 days, just cosmetically they would like to have them kind of hidden. You'll see some surgeons want to bury the knots. Just make sure that they do have a proper closure on the incision.
One thing that I would add from a surgery perspective is that I generally ask the doctors to spread the mouth open a little bit so that you can really visualize the incision very well. And I do that with one hand as opposed to doing it with like a pair of pickups. I prefer to do it with my fingers to really, that way I can kind of bend it kind of toward myself so that I can really see it very well. Now the point that Gayla was making about the closure of the incision is that if you'll notice, if I just take just a little thin little amount of the mucosa to close it, I can get it closed and that's just fine. But the problem is that because we have an implant underneath, we need to protect it. So we need more tissue between the implant and the incision. So I generally go deep and grab a lot more tissue than just the little thinnest, most superficial layer of mucosa. And I feel much better about my closures for it. Also, make sure or just make note of how many knots that the surgeons tie. This suture typically requires a few more knots than other sutures do, and so if this surgeon just does a couple, you might have to even intervene and make a little recommendation that the company recommends 6 or 8 knots. I generally try to put in 8 knots myself. So let's count them together really quick. 1, 2, 3, 4, 5, 6, 7, 8. And that concludes this portion of the procedure.
Now, once the procedure is completed, I've removed the drapes, and then as a courtesy, which every physician's office will do, I'm going to remove your betadine prep. And I do that with anyone, even if you can't see it, just so you don't have any type of skin irritation. Once this has been removed, then I will review with the patient instructions, and the instructions are mainly going to be that the patient for the first week needs to minimize the opening of their mouth, and that means that they need to avoid like excessive gum chewing, things that would cause a lot of stress on the incision sites. The rule of thumb that I usually tell the patients is they need to minimize the opening of their mouth and not open it any more than about a ½ inch for the first week. And then the second week, I let them go back to what I consider a normal movement of the mouth, but it will be 14 days completed before I'll let the patient do any type of stretching or opening of the mouth. Now, some patients will ask if they can go to the dentist, and I recommend that they wait at least 6 weeks to 2 months. That way the incision sites have completely healed, and also the capsule that forms around this implant is soft enough for them to maintain holding their mouth open for a period of time without them having any restrictions or discomfort. The other instructions that we'll review with the patient is one that on the day of surgery, I usually ask if there are no allergies to any type of antibiotic solution, that they basically coat and keep their lips well coated the first day with an antibiotic ointment. Now, the remainder of the 2 weeks, and I do tell patients that they do need to keep some form of moisturizer, preferably a petroleum-based product, on their lips for the next 2 weeks. But the first day, I always make sure that we've got a really good coating of the antibiotic ointment on the lips, and then I instruct the patients that after each meal, they will need to rinse their mouth with either diluted peroxide or like half-strength diluted peroxide, or half-strength mouthwash after any meal. And the reason why, it'll remove food particles which could gather around the incision site. After they have rinsed with the either peroxide or the mouthwash, then I ask that at least 3 times a day they clean their incision sites with diluted peroxide, that would be half water, half peroxide, and then apply antibiotic ointment. Now, when a patient opens their mouth, I always make sure that they do a minimal opening because they're going to be used to opening excessive. So after they have cleaned their incision site and on the first day, then I ask that they put just a little antibiotic ointment in that corner. The antibiotic ointment the first day, and then remember they can go with just Vaseline, Aquaphor, Carmex, something after that. But for the remainder of the 2 weeks, the incision sites need to be cleaned with the half-strength peroxide and water and antibiotic ointment applied to the incision sites. But the remainder of the lips, they can do either the petroleum or the Carmex. And they'll do this for the 14 days. Now, for the first week, the patient will not do any type of massage or movement of the implant. I usually ask the surgeon's offices that the patient comes back at 1 week, and then we'll demonstrate how to center the implants. And then I also at that appointment show the patients the stretching exercises that are important and will need to be maintained and done for the first 2 months after the procedure to keep the scar tissue or the capsule that forms around an implant open and soft so that the patient loses no mobility or has any restrictions of her mouth movement. The remainder of the instructions that need to be reviewed with the patient is one, that she needs to sleep on her back with her head elevated for about the first 2 weeks. You'll notice that that will minimize swelling. You'll have some patients that won't really comply with that, or some surgeons that feel like that's an overkill. But I just recommend that to patients because that will really minimize the swelling. Remember that patients need to be informed that their swelling and their bruising is very comparable and comparable to an injectable. If a patient hasn't had an injectable previously, then I always tell them that their lips by tomorrow morning may be 2 to 3 times the normal size prior to surgery. I recommend cool compresses to the patients, and when I do cool compresses, I always tell the offices there is not to be direct ice placed on the skin, but you need to have a barrier of a cold, wet compress with maybe a little ice on top of that. Patients that do direct ice or have too cold of a compress on their lips complain of more stinging and discomfort than patients that just keep cool compresses. I even recommend some patients just make a bowl of ice water and just keep some 4x4s in them and just exchange them out. But I do recommend today that they go home, they rest the first day of surgery, and they just pretty much keep their cool compresses on continuously, and then for the remainder